We have always at MD Anderson considered that we need to cure patients with follicular lymphoma or with any kind of lymphoma. We've always had that attitude and that approach. The problem is that in the past, regardless of what therapy we've administered and what kind of chemotherapy we've attempted to give patients with follicular lymphoma or slow-growing lymphomas, they invariably develop disease progression. That means to say the disease comes back. What we have observed clinically is that at a follow-up of about 20 or 30 years even, only about 5 to 10% of patients with follicular lymphoma will still remain free of disease. Now that patients are being treated with rituximab at the very beginning, rituximab not only delays the chance of their developing recurrence, now perhaps pushing it out to even 5 or 6 or even 7 years later, or perhaps even longer, it is also, it appears, to be improving the survival of these patients. So the question is, if you live with your disease for a long period of time and ultimately, let's say 30 or 40 years, die of some cause other than the lymphoma, it therefore becomes a process of managing the disease rather than curing it. And this is a big step towards eventually curing the disease. So therefore, rituximab and all these new agents, which are going to become available and commercially available in the United States within the next 2 or 3 years, are going to make a big impact on not only how we treat the disease or manage the disease, but also ultimately increase the number of patients who still are living with the disease when they ultimately die of some other cause. I really believe that major cancer centers, as well as other larger center trials, are both important. For example, there are trials that are ongoing currently in the United States that look at broad questions regarding large numbers of patients, trying to make some sense out of whether a transplant works in a particular group of patients, or whether certain agents can be added to standard therapies. These are very important trials because they look at large number of patients and try to make some sense out of rather broad questions. But then there are some newer agents, perhaps, which are only available and are best studied in smaller centers or in centers that focus specifically on that disease. The reason that's important is because then when the patient is treated, we're able to get a lot more detailed information about how well the drug is tolerated. We're able to understand a lot more about what kind of responses the patients get, about how well the patients like the treatment, and about what subsequently happens as far as the disease, whether it develops progression, about what it looks like, and other information about the disease and the drug itself. We at MD Anderson are always looking to improve upon standard therapies. And I personally believe that a clinical trial represents the culmination not only of knowledge about the disease and standard therapies, but also knowledge about newer drugs and about better management of those diseases and how well patients will do when they receive those treatments. I personally have always been interested in education. I'm afraid that currently there is so much happening in the management of lymphoma, especially the slow-growing lymphomas. We have now so many new drugs and so many changes are taking place in our understanding of these diseases on both a cellular and molecular level that many people just are not keeping up with the current literature. It's difficult enough for someone who is a lymphoma expert to keep up with the literature, with the volume of material that is coming through. The number of trials that are available is is incredible. It's really expanded very rapidly and very broadly to include a lot of new drugs and a lot of new therapies. And making a decision as to what direction to go is sometimes difficult in a research or other clinical setting. So I think there is an urgency to disseminate information, to educate people, not only physicians but also patients alike, to understand that there is a lot that is going on now in the management of all lymphomas, but in particular indolent lymphomas, where we have so much more to do and accomplish. Well, the tissue bank has only been available now for about 1.5 years. Dr. Sattva Nilapu is running that particular tissue bank and is in control and in charge of the committee that allows the tissues to be used. Currently, we are getting requests for use of tissue in the tissue bank, and it is looked at by the committee. Each request is looked at very seriously. The tissue bank is a storage facility where biopsies that are obtained on patients, if we have additional tissue that is available and the patient agrees, we store some of those lymphoma tissues for use for research purposes in the future. We are not certain exactly necessarily what research purpose it is at the time, but we are harvesting their tumor cells and putting them in the tissue bank. This includes sources not only from lymph node biopsies but also blood and bone marrow sources. So we're using that tissue, saving it back, and using it in the future for additional research purposes. This is a vital part of research programs in this country to understand more about how patients tolerate their therapy as well as how well the diseases respond to that therapy. We were very fortunate to be able to get an initial large donation from a patient and her husband, and are currently expanding that program and are soliciting donations from other from donors outside of the center as well as in the center, and are very interested in anyone who wants to be able to donate tissue as well for that particular tissue bank. So if you have a biopsy that needs to be done and you are suspected of having lymphoma, having your biopsy done at MD Anderson is a good thing to do.